Morning and welcome to the weekly dementia blog being sponsored by Spectrum Ed. My name is Dr. David Hutchings, and we're excited to start a three-part series over the next 3 weeks talking about the importance of therapies in the world of dementia. So we're going to talk about dementia as a whole, and then I'll start to kind of dissect a little bit by type. But again, as we define dementia, and it's one of the biggest questions I get most often, is what's the difference in dementia and Alzheimer's. So again, as I explained in previous blogs, dementia is an umbrella term, very similar to cancer. We have many types of cancer that fall under the umbrella of the term cancer, just like we have many different types of dementia that fall under that, Alzheimer's being one of the most common. So I can say that I refer to therapies, physical therapy, occupational therapy, and speech-language pathology with nearly every one of my patients. Just as a recap for those who are non-clinical, physical therapy is going to work with more the mobility and the functional pieces of it. And that's what I'm going to talk about this morning. And then occupational therapy is really critical because they have more of the functional pieces and activities of daily living, which we're going to talk about next week. And then the following week, we're going to discuss speech-language pathology and the impacts on speaking and swallowing and nutrition and the risks that poses for the patient. So let's begin with the physical abnormalities. Again, most people think of dementia as impacting memory, but it impacts all mental and physical abilities, completely all the mental and physical abilities. So what we'll see is that we'll have patients who have gait abnormalities, they have postural issues, they already have failing eyesight, they have balance problems, and they'll have obstacle avoidance issues. So if a patient is in their home and trying to move around an object, they'll be unwilling to do that and increases their risk for falls. Plus, they have spatial orientation issues. So many of you have probably seen the clock drawing test where we'll have a patient draw a clock and then we have them put a certain time on the clock. Well, this tells us not only concentration and ability to carry through an advanced task, but also it tells us spatial orientation. So an example of that would be if I'm driving down the road and I have a car stopped in front of me, I know exactly how much to apply my brake because I can see that distance between me and the car in front of me. Well, that's spatial orientation. And as it begins to decline, that does increase our risk for falls. So the falls are a big issue and mobility are a big issue because, yes, we're at risk for a fall and a hip fracture. We're all aware of that. What we don't discuss a lot, though, is a fall and a head injury. Or maybe this is a fall and we don't have an injury, but then we go to the hospital. And then what happens, we have a change in environment, and we can see a massive decline in patients who have a change in environment, even without a hip fracture or head injury. Also, as dementia begins to progress, we lose the ability to have trunk control and hold ourselves up in the chair. We don't move around a lot, so we increase our risk for blood clots. And also, one area that we don't talk a lot about physical therapy about, but they are critical in the area of wounds. And we see this in dementia quite often. So maybe offloading a certain pressure, moving in different positioning, and other adaptive devices to keep the patient comfortable and also reduce the risk for wounds. As I mentioned before, we also have a condition called apraxia, and this is the loss of motor memory movements. So walking is a great example of that, or upper extremity movements. We lose the ability to have that motor memory. So this increases our risk for falls as well. Lastly, I'll say that different forms of dementia demonstrated different gait patterns as well. So a vascular dementia patient, we can have a very shuffling type gait, just as we would see in like a Parkinson's with dementia or a Lewy body. And then also Alzheimer's presents gait abnormalities as well. And then one of the things that I really look for very often is if we're looking for patients and say, okay, is this a reversible type of dementia? For example, normal pressure hydrocephalus. I've had patients with this before where they present Alzheimer's symptoms and they're diagnosed with Alzheimer's. However, they have fluid around the brain called normal pressure hydrocephalus. And this creates a gait pattern. It's almost like a drunk gait, or someone's maybe in a boat and they're kind of off pattern. So that's not a gait pattern that would be vindictive to an Alzheimer's disease. So gait abnormalities can tell us a lot about the type of dementia, but also it can help us with the physical therapy piece of it, of reducing the risk of falls, reducing the risk of head injuries, hip fractures, as well as the development of wounds and also the healing of wounds. So physical therapy is critical in the patients with dementia. Next week, we're going to go into a little bit of occupational therapy and the functional side of things and the activities of daily living, and we'll define that for you. Again, three-part series on physical therapy, occupational and speech language pathology. The therapies are absolutely critical, not only for the patient, their physical declines, their cognitive declines, but also the quality of life, and most importantly, is also reducing some of the risk and the burden on the caregiver as well. Again, thank you, and we will see you all again next week. Thanks.